Hello. So we're going to talk about drugs for mania in this particular video. So before we go to the drugs, let's see what is mania exactly. Now, mania is a condition. It usually is a state of. It's an opposite of depression, and so the patient is super excited, or it is hyper excitable patient. He is overactive. He is he can be aggressive. Then there can be he will be less of sleep. He'll have less of sleep. He's like super excited, so less of sleep are there. He'll be more than हद से ज़्यादा optimistic and energetic and all those things. But they can be sometimes pressed for speech इतनी अच्छी तरह because he's too hyperactive. He'll be like difficult to speak, and he can have grand delusions like he's grand and he's big and he's this and he's that and whatever he's saying is correct. He's the the master of the universe. That kind of feeling he has in mania. So that's mania. Now, mania usually occurs alongside depression. मतलब, the patient usually they have maniac depressive psychosis. So there is mania and there is depression. Or because mania bhi hai, depression bhi hai, so there are two poles. So it is also called as bipolar disorder. So sometimes patient will be in mania. Then there will be a gap, and यहाँ पे the patient can be absolutely normal. Then the patient will go into depression, right? And then again the same, then normal, then mania, depression, or depression, or mania, whatever. So these are two poles, so therefore it's called as bipolar disorder, and both things can coexist. So when the patient is in depressed state, you can give him drugs which are going to take care of depression. In the manic state, we give drugs to take care of the mania. Now, what are those drugs that we can give to take care of the mania? Now, see, one is that patient is in the manic state, like इस time पे उसको mania is in acute mania से कहते हैं. So we have drugs for that, and we have drugs which are going to help prevent another attack of mania. So that's for prophylaxis. So these drugs do that also. So we have three actually classes. The first drug is the lone drug which is called as lithium carbonate. The second are actually, they are anti-epileptic drugs, but they also have been found to be useful in cases of mania. So these drugs are like valproate, carbamazepine, and the newer anti-epileptic which is lamotrigine. Then atypical psychotics. Certain atypical psychotics have also found to be useful in mania. Atypical antipsychotics. In this we have olanzapine, risperidone, quetiapine, and aripiprazole. These are the drugs which are used for management of mania. Now we've already done what is anti-epileptics, and we have covered the atypical antipsychotics. So the mechanism and everything. For mania, it is not really clear how they work, but they just do work. So we are not going to talk in detail about these drugs. We are going to actually focus mainly on the lithium carbonate. So let's start with the lithium. So what is the mechanism of action of lithium? Now there is a hypothesis given that in the brain, because in mania there is overactivity, so certain neurotransmitters are found to be overactive in the brain. Like for example noradrenaline, which are stimulant. They are stimulating the central nervous system. They have been found to be overactive in the brain. And how they work, these neurotransmitters, that is with the help of calcium, right? The calcium leads to the stimulatory effect, and this calcium is released because they have their G protein coupled receptors, and जब उन receptors पे ये neurotransmitters act करते हैं, they lead to series of changes. The second the second messengers are there, and they are then going to lead to increase in the level of calcium and the stimulatory effect. So what lithium does, lithium actually is supposed to block this, the second messenger system, so that the calcium excess is not generated, and they are going to decrease the activity of these neurotransmitters, right? So the G protein coupled receptors अगर suppose यहाँ पे है, ठीक है? So these G protein coupled receptors which work by this are the GQ type. Now when they're stimulated, they are going to lead to these series of actions. So what happens here is the PIP2, ठीक है, PIP2 phospholipase enzyme की वजह से they are broken down into two main substances. One is the diacyl glycerol and the other is the IP3. Okay, that is what they do. And both this IP3 ultimately what it does, it increases the level of calcium and it produces the action. This is a stimulant action. Even the diacyl glycerol, which doesn't come out from this cell membrane, it stimulates phosphokinase C, and it also helps in increasing the calcium levels and ultimately performing the action. Now what happens when this is done? This IP3 inositol, the inositol triphosphate breaks down into IP2. IP2 breaks down into inositol monophosphate, then into inositol, and then so on and so forth. This is the precursor of the second messenger system. The whole precursor is this. Now what does lithium do basically? It inhibits the conversion of inositol diphosphate to inositol monophosphate. Here it is going to stop this thing. So when this thing is stopped, there is no inositol phosphate formed and no inositol formed, and because of this, this whole circle is going to be disturbed. So this cycle is not going to progress, and when the cycle doesn't progress, definitely there's no going to be there's no generation of PIP2, and then it won't be able to break down into diacylglycerol as well as the inositol triphosphate. So this is how it will cut down on this cycle. It will break the cycle and decrease the activity of the stimulatory neurotransmitter. That's one hypothesis which is given for this particular drug. The other hypothesis which is given, number 2, is that there are certain kinases which is called as glycogen synthase kinase 3 or GSK3. This is also inhibited by lithium. And what is the role of this glycogen synthase kinase actually is they break down the brain derived neurotrophic factor. So they are going to actually break down brain derived neurotrophic factor into its metabolites. So when lithium inhibits this, then brain derived neurotrophic factor won't be able to break down the metabolites, and they're protective in nature and they won't be actually then causing any symptoms. So these are the two hypotheses which is actually given for mania. So one is inhibition of conversion of inositol diphosphate to inositol monophosphate, and the other is inhibits the GSK3. Now let's come to the important points in the pharmacokinetics. Now इसकी pharmacokinetics इसलिए important है because इसकी जो half life है, the T half, is quite long. It is 24 hours and it takes about steady state is 4 to 5 half lives. So steady state is achieved in about 5 days, right? So for its effect to actually occur, this effect basically, for this effect to occur, it takes about 2 weeks. Actually जब इसका इफेक्ट आना शुरू होता है, it takes about 2 weeks to work out. So it cannot be really used for immediate control of mania. So you will have to give some other drugs that are more effective at that particular stage. But it can definitely prevent the further attack of mania. Study said in 5 days. Another important thing is this, that when you have to give this drug, the sodium status should be sodium status of the body in the body. It should be normal. In case there is hyponatremia in the body, if there is hyponatremia, because sodium is also a monovalent cation and lithium is also a monovalent cation, so body treats them as same. So if there is deficiency of sodium in the body, so you see how do your kidneys try to overcome that? They are going to reabsorb from the kidneys the sodium ions, but even उसके साथ साथ they are going to reabsorb even the lithium ions. तो क्या होएगा फिर? lithium ions body के अंदर the levels are going to be higher and that can lead to lithium toxicity. And why are we so concerned about this? Because lithium has a very very narrow therapeutic index. Or therapeutic margin is very narrow. Okay, a slight increase in dose and it goes here and there. So this is an ideal candidate for therapeutic drug monitoring. So you have to do the monitoring of these drugs so that to make sure that their levels stay within the permissible levels. So acute में है कि prophylaxis के लिए दे रहे हो, they should always stay in the permissible levels because of the very narrow therapeutic index. You have to be very careful about that. Now the other effects of lithium, which are also, you can say, the kind of side effects also they have. The first important effect it can cause hypothyroidism in the patient. Hypothyroidism. It will inhibit the antidiuretic hormone. So when it increases the inhibits the antidiuretic hormone, it leads to a condition called as diabetes insipidus, right? Then it can increase the leukocyte count in the body. Increase the leukocytes count in the body. Because it also there is sodium retention along with it, and whatever भी हो जाएगा, it can lead to edema. That's another highlight with this particular drug. Then it can lead to tremors. अगर tremors already है किसी में तो increase करेगा tremors. And these tremors can be treated with beta blocker, which is propranolol. So these are the other effects shown by lithium, and if you see closely, they can be also labeled as its side effects. So other ADRs apart from this, what can happen? Like if it is given in pregnancy, especially in the first trimester, so it can harm the fetus. So it can cause cardiovascular congenital anomaly, which is called as, very important, Epstein's anomaly. Epstein's anomaly. So therefore, in case the patient has a maniac episode in the first trimester, we should not give lithium in the first, where the organs are forming. So we can give atypical antipsychotics. They are preferred in the first trimester. So don't give them in the first trimester. In case there is toxicity or overdose with lithium, we don't have a specific antidote for this. So the best possible therapy is that you do hemodialysis and remove it from the body. That's the best possible thing that can be done. Right? Now coming to the uses, as I said, it is used either for acute mania episode or prophylaxis. But acute mania episode where you can start the drug, start lithium, but it will take about 2 weeks to show the response. So also start lithium, plus you can give the atypical antipsychotic. Atypical antipsychotic like aripiprazole. That's a very good antipsychotic. And you can also give, if it is still not controlled, a benzodiazepine like diazepam or lorazepam can be given. They can take care of the acute attack. And gradually what happens, when the lithium starts showing the response, you can withdraw these drugs. For prophylaxis of mania, lithium is a very good drug. This is one of the drugs which can prevent suicidal tendencies in these patients. So it is very good. But yes, there are alternatives. Let's say lithium नहीं tolerable है या कुछ और problem है, we can use valproate. We can use carbamazepine in these drugs. And we can use lamotrigine. Suppose there is also a depressive, episode there. So for depression, it is very good. Patient को depressive episode आ रहा है इसके बाद, so it is pretty good for that. And valproate has less side effects, and it is very good for prophylaxis of these particular drugs, mania. So acute and prophylaxis के लिए. Then drug interactions actually of lithium with diuretics are, with diuretics हो या NSAIDs हो या ACE inhibitors हो, they almost have the same kind of effect, because क्या होता है diuretics के साथ, especially we're talking about thiazides and loop diuretics. They lead to loss of sodium ions, right? So your body tries to compensate them by absorbing the sodium ions, and जब absorb होएगी sodium ions, so there will be reabsorption. So body will try to reabsorb sodium ions as well as the lithium ions. So patient again will land in lithium toxicity. Similarly, in NSAIDs also, there is increase in the lithium levels in the body. With insulin, diabetic patients who are on insulin, this also has an insulin-like effect. Now lithium, another important thing, it has insulin-like effect on the glucose metabolism. So if we are giving it in diabetic patients, here it will increase the effect of insulin. Therefore, there can be hypoglycemia. Okay? So there can be hypoglycemia. So these are the main points about lithium. So let's just take a quick look again at what lithium is all about. So we are doing the drugs for mania, right? So in the drugs for mania, we have done the important drugs which we have is lithium carbonate. That's the most important. And other drugs also are good for mania are antiepileptics and certain atypical antipsychotics. Now lithium inhibits the conversion of IP2 to IP, and therefore it will not allow the second messenger system of neurotransmitters to function, and therefore the neurotransmitters are not going to act. For example, especially noradrenaline, which is very CNS stimulants basically of them. So it can do that, and it needs at least 2 weeks for production of this effect. This is also said to inhibit the GSK3, and therefore it will not allow the brain-derived neurotrophic factor to get metabolized. In the kinetics, just remember that sodium status of the patient should be checked when you're giving lithium. Otherwise, body tends to treat lithium in the similar way as sodium, and the reabsorption of sodium along with lithium takes place, and that can lead to lithium toxicity. Also, it has a very, very narrow therapeutic index, and it is a good candidate for therapeutic drug monitoring. Other effects, which are also the side effects, it can cause hypothyroidism, it can cause diabetes insipidus-like state, it can cause edema, increase in the leukocytes, and the tremors. Pregnancy may, specifically if you're given the first trimester of pregnancy, the baby will have a heart anomaly, congenital heart anomaly called as Epstein's anomaly. And if there is an overdose with lithium, the only probable mechanism best for treating that overdose is by hemodialysis. Uses, they can be started in an acute episode of mania, but they're not going to be effective very soon. So for that matter, you give it along with, so it's lithium doge, but along with an atypical antipsychotic, and still if it is not showing any benefit, then you give benzodiazepines, very quick acting. Prophylaxis mein, this is one of the best drugs available for prophylaxis, but yes, in case the patient is not able to tolerate lithium for some reason, then you can give safer drugs like valproate, carbamazepine, and lamotrigine. Drug interactions with the drugs which tend to cause sodium loss in the body, or that kind of an effect is there. They are because body is going to reabsorb those ions back, alongside the lithium is also going to be reabsorbed back. Now that is very, very important when we talk about diuretics. With NSAIDs and ACE inhibitors, they say that with this also they cause an increase in the absorption of the lithium. So again, it is going to be the same thing. Insulin, it has same effect of insulin. So अगर diabetic patients में insulin चल रही है and they're also given lithium, so both of them are going to decrease the blood glucose levels and patient can land in hypoglycemia. So there you would need adjustments in the level of insulin when you're treating the patient with diabetes mellitus. Right? So with this, we come to the end of this lecture on mania. So just go through that this lecture again, video again, make your tiny important notes. And yes, this is pretty important when it comes to your MCQs or the university examination. Management of mania is pretty important, or writing a note on lithium, that is pretty good. So yes, so take care, see you in the next lecture, study hard, and see you in the next lecture. Bye bye.